We're very happy to welcome you and really looking forward to the discussions and the questions this morning. This is our first public engagement event to discuss the integrated care system, but it does follow on from two events we held in January and February for members of the voluntary and community and social enterprise sector. So we're really looking forward to continuing this discussion with you. We have received a number of questions as part of your booking, so we will endeavour to answer those throughout this morning. But do please post your questions in the chat, and we do have question and answer time in the sessions this morning. So if we could have the next slide, please. We've got, and I should say that's just to give you a flavour of the agenda. So you can see we've got a range of speakers talking about partnership working and the integrated care system, and we have time for questions and answers. I should also say we will be sending out this presentation along with a link to an evaluation form either later on today or tomorrow. So do please post your questions in the chat throughout the sessions. Thanks, Diane. So before we get started, just to take a temperature check, we're keen to understand whether you know what the integrated care system is and what it might mean for you as a resident of South East London. So we're just going to put a link to a dood poll in the chat. So please do link on to click that link in the chat so we can see what the level of understanding is, and we will be coming back to these questions at the end of the session to see whether there's been any change. Oh, my eyes, sorry, is that 54% of people? Thank you. So 54%. I think that's just gone up to 56%. So that's good. Over half the participants today know what an integrated care system is, but there's 44% and don't know what it means for them. So we would hope that throughout today's session that we would be able to explain to more people so we can have further understanding of what the integrated care system is for people, but we would really build on the knowledge that what you would understand what it means for you. So we will come back to those questions at the end. So I think that's 56 and 45. Sorry, that I am really struggling to see that. Without much further ado then. Oh, that's really, oh, sorry, this is the second question. So 23% know what it means for them and 77 don't. Okay, so we really hope to build onto that knowledge throughout today. I'm going to hand over to Richard Douglas, who's our chair designate for the integrated care system, to welcome us to the meeting. Thank you.
Hello everyone, as Rosemary says, my name is Richard Douglas. I'm Chair Designate for the Integrated Care Board, and just a sort of few minutes from me at the start to introduce the session before we get into the meat of it. So welcome to you all, and it's great to see so many people joining us. Last time I looked it was knocking towards 100, so that's fantastic. And it's fantastic because it's really important that we engage with you, both not just in explaining what the ICS is and does, but also in helping shape that. Yeah, the ICS is something different than we've ever had before in the NHS, and we want it to both be and to feel different. It is about the whole being greater than the sum of the parts. Our aim is for it to be a true partnership of all the organisations that contribute to health and care of the population of South East London, whether they're GPs, hospitals, local authorities, community health providers, voluntary and community partnerships. It's about bringing all of those together to achieve that one single aim of really making a difference to our population's health. And by coming together, we believe we can achieve something special and truly transform the health and population of South East London. It won't happen overnight. No one's going to kid you that you can do these things in a week or in a day or in a month. But we believe that together we can really build something great. And that's why today is so important for us. It's part of a process, not just of improving your understanding of us, as Rosemary says, of sort of getting those percentage numbers up. But more importantly, it's about helping you or giving you the chance to help shape what we do and how we do it. Yeah, I hope at the end of this you'll feel you'll understand the ICS better. I hope you'll feel that you will understand better what it can do for you, but also I hope that you will understand better how you can contribute to the ICS itself and how you can help us develop. So I hope you enjoy the session, and at that point I will hand over to Angela Barn, I believe.
Yes, thank you very much, Richard. So as Richard has said, I'm Dr. Angela Barn. I'm the Borough Director for Bromley, for South East London CCG, and I'm also a consultant in public health. So the pandemic really was something that I had some expertise, not in managing a pandemic or responding to a pandemic, but from the public health point of view, I had some experience from the previous avian flu and outbreaks and the flu pandemic from about a decade ago. So talking about partnership working, and I wonder if we could have my first slide. Thank you very much for that. Working together has always been really important to staff who work in the NHS. We've worked very closely with people in the council, between different organisations, and also with different community organisations and what we sometimes call the third sector, but these are voluntary organisations, and we'll hear from Naomi a little bit later on who heads up one of these organisations. But we've faced unprecedented pressures from the COVID-19 pandemic, which started in March 2020 in this country. So we were, like the rest of the world, really, we had to find ways of responding to the situation. And really the existing collaboration between all of the boroughs and within the boroughs meant that we were able to respond appropriately to what faced us. What we see later this year is legislation coming into effect, which will see those partnerships, those formal partnerships, becoming even more formal. They'll become statutory. And this is what the integrated care system really is. It's about our partnership working, so we deliver the best care that we possibly can do. And we are able to reduce overlaps between different organisations and ensure that where people need services, they don't fall through the cracks between organisations. And this process doesn't happen on one day and not on a previous day, but it's something that has evolved gradually, and we in South East London have seen that actually this is the best way to deliver care. We want to show you how this is, these changes have meant that in South East London we've delivered a very effective vaccination programme. One of the pillars that we have in response to the COVID-19 pandemic, and you'll hear from 2 or 3 speakers about this. You'll also hear from Professor Soni, who will talk about the role of pharmacists in what we've been doing, and I will talk a little bit more about how we have worked together to deliver this integrated care. So without further ado, I'm going to hand over to Naomi, who's Director of Strategy at Metro in Greenwich. So can we have the next slide, please? And can Naomi put on her camera.
I can, amazingly. The IT is working. I don't think that's my slide. I don't work in Bromley. I work in Greenwich. Ah, there we go.
I do beg your pardon, Naomi. That was my slide, but I'll come back to the partnership working in Bromley later on.
So very, very quickly, my name's Naomi Goldberg. I'm Director of Strategy for a quite large charity, £5 million turnover charity called Metro. But actually one of my responsibilities is to manage an area of Metro called Metro GAVS, and GAVS stands for Greenwich Action for Voluntary Service. And the role of that bit of Metro is to support the voluntary and community sector in the Royal Borough of Greenwich. And we do that in two ways. One, by supporting organisations to get better, whether that's helping with funding, with governance, ensuring that they're representing the voice of the service users that they support, you name it, we'll help them. And the other area that we do is we support the sector to ensure that it does get voice and that it's heard. And the main reason for that is actually the sector gets to parts of the community that the NHS, social care, housing, you name it, quite often can't get to. And so I always see it as the concrete or the bit that holds together civil society within any local area. And without us, everything will just fall to pieces. In Greenwich, there's just over 1,000 voluntary and community organisations, ranging from a small tenants association that may only put on an outing maybe once a year to quite large organisations like the Hospice, like my organisation, Charlton Athletic Community Trust, that have turnovers of over £5 million. And then everything in between: heritage organisations, sports organisations, social care organisations, advice organisations, you name it. We are there, providing that key element to actually what makes a borough, a place in anywhere in the world, actually a great place to be. So I'm going to talk actually about a specific bit around the pandemic, which is around the vaccine work that we did, and try to demonstrate to you that with the voluntary and community sector, the pandemic and where we are now is because of some of the work that we did. So one of the key bits that those of you who I'm sure you all went for your vaccines, would have noticed there was loads of volunteers. There were lots of people going, please, can you sit here? Can you go here? Can you wait here for 15 minutes? Well, those volunteers were probably provided by a volunteer centre. And they went through some micro training, they had their DBS checks done and all that, and they were supported to be able to do that work. And in Greenwich, I think there were about 400 volunteers that were provided over the last booster process. And without that, again, would have been chaos, wouldn't there? Because people wouldn't have known where to sit, how to move through the system and things like that. Throughout the pandemic, but I think really importantly as part of the vaccine process, groups I've either self-funded or got funding, mainly through public health in the Royal Borough of Greenwich, to deliver a range of projects to communities that have been less likely to come forward. So whether that's in Greenwich, the Nepali community, the West African Francophone community, the Vietnamese community, people have put on events, people have gone out and talked face to face with people to encourage them to understand why going to have a vaccine is a good idea. And that has worked in Greenwich. We're not brilliant. Greenwich isn't the most perfect borough in the world, but if you look at our figures, particularly around ethnic minority communities, we are doing better than average because, my view is because we did a lot of work around that. But another bit of work that I think has been really essential is the community champions work that again has been led by public health, but involves the voluntary and community sector. And that has been working to find individuals who are willing to go out and talk to people on an individual basis about the vaccine process. And many of the community leaders come from the voluntary and community sector. The reason why people get involved in the voluntary and community sector quite often is because they want to change things. And so many of them have become community champions and have got very deeply involved in going out and talking to their families and friends to try to get people to understand better why vaccines do work, and they haven't got chips inside them, and they aren't likely to cause you some sort of dreadful disease. So I think again that has worked really well within Greenwich. And then I think the thing that I think is really important, I think, about the sector is that we have all these tentacles all over the place. And what we're great at is providing information, not just to our communities, but also back to the rest of the system. So in Greenwich, the system has listened to us and changed the way it provides vaccines so that it meets the needs of local communities. So Greenwich was the first vaccine bus, we think. And that was because we were saying people aren't willing to come to places. You have to go out to places. Lots of people have vaccine buses now. But so, yeah, and just things like how you actually talk to different communities will differ. Having people, did quite a lot of videos. South East London ICS did a lot of videos, but we actually had people that came from relevant communities. So they looked like the people we were trying to urge to get vaccines. And then last but not least, but actually a thing that I think is really, really important is maybe a bit that hasn't really been acknowledged during the vaccine process, is just the amount of work that people in the voluntary and community sector did to help people get a vaccine, because they hadn't got access to a computer, because trying to phone the vaccine number was really difficult. So people actually booked people to get vaccines. People escorted people to vaccine centres. People provided cars and things like that. And that's probably one of the unheard bits of the vaccine process. But as I say, the sum of us, and I don't just mean the voluntary and community sector, but the sum of the system, but also the sum of the voluntary sector, is much greater than the sum of its parts. And without us, I don't think the amazing vaccine work that's been done within this country, within South East London and Greenwich, would have been as good. That's me done. Thank you. And I'm handing over to Jo Turville, I think. Is that correct?
Thank you very much, Naomi. We'll go on to hear more about the vaccination programme through Jo Turville, who I think is with us now. Jo.
Hello, can you hear me? Yep, great.
Yeah.
Hi, hello everybody. I'm Jo Turville. I'm Director of Operations at Guy's and St Thomas's, and had the great pleasure and opportunity of leading the vaccination service there for the last 15 months, and also working really with the leadership across South East London to deliver the amazing vaccination programme that we have thus far. So I think from my point of view, I was asked to talk about the hospital involvement in the vaccination work, but I think really, as we've just heard, it's a really a cross-sector and cross-organisation effort that has been phenomenal, and a really good example of how we have worked really well across the sector. From the point of view of the hospital, so we were all asked to stand up hospital hubs early on, predominantly to vaccinate our staff. However, a couple of days before the vaccination work started, we were then asked to broaden that in acknowledgement of this was a population-wide vaccination programme, that we needed as much capacity as we could possibly have across the country. So we broadened, with a few days' notice, we broadened into becoming vaccination centres across many of our hospitals. So you can see from the slide, the hospitals that were involved all stood up really quickly and really well, and worked together. We provide mutual aid to each other. We've worked in a very collaborative way across the hospitals that perhaps hasn't always been there, but has really been apparent for the vaccination work. So we provide mutual aid, as we call it, for vaccinations if we need to. We've had to at times move vaccinations across to other hospital sites because of demand very quickly overnight. We provide staff across the patch to all the different hospitals. So at Guy's and St Thomas's, we're the workforce leads. So we've trained many staff from all different backgrounds. Some of our lovely volunteers have come through the training and become vaccinators. Also people from airlines and hotels and all sorts of different walks of life have come through the vaccination programme and been trained to work either in our hospitals or in fact in our GPs, with our primary care networks, with our community pharmacies. So really good example of partnership working in practice. We continue to work in this way as the vaccination programme continues, and we will work together to address the next phase that comes along our way. I think that was all I had to say, Angela.
Thank you very much, Jo. So shall we move on? Professor Soni, Ash, are you able to talk a little bit about the work done through pharmacies? Okay, I can't see Professor Sony in the chat. Let me talk a little bit about the partnership working during the pandemic. So I talked a little bit about the joined up services that we were producing across the whole of South East London, and also within each of the boroughs. Each borough has a partnership. In Bromley, we call this one Bromley, and we've all been doing similar sorts of work. We've been trying to support discharge arrangements through our hospitals to ensure that there's the capacity for people who are ill with COVID or other serious illnesses. We've set up community COVID services, and of course we've played a key role in the vaccination programme. So this comes back to the point that Richard made earlier on, that what we do individually when we put it together is greater than the sum of the parts. And if I could just have the slide pack back up to just describe some of the partnership working during the pandemic. What we've done is in South East London, we've given nearly 4 million doses of COVID vaccine, and that includes nearly 1 million doses of booster vaccine doses. And that process, those vaccinations are still going on. They're still available for people to have even their first dose, their second dose, or a booster dose. We've heard something about the vaccination sites that have been talked about. The whole population has worked with us, whether they're working in a third sector organisation or community organisation, or in the NHS to support what we've been trying to do. So we've held these vaccination sites in in pharmacies, in care homes. We've also held them in doctors' surgeries and community buildings and council buildings. So really, this has been a joined up working arrangement between the NHS, councils, all of our partners and the population. And what we've done is to look at how we're doing. We've developed dashboards to look at our vaccination uptake, and we've tried to identify certain populations or certain areas where uptake hasn't been as good as we would like, and we have worked with our partners to try and improve things in those areas. So if we've had more than 1,000 vaccinators trained up across South East London, and Joe has just talked about that. And what that has helped us to do is to tackle vaccine hesitancy. We know by the data and by speaking to people at local population level that not everybody has as much confidence in the vaccine or at the NHS as we would like, and we have had to continually engage with our partners with these populations, and we've also enlisted the help of our local politicians and our MPs to help us with some of those processes. So if we can move on to the next slide, what we've seen with the vaccination programme is a reduction in many of those inequalities in vaccination. Now, just talking a little bit about the kinds of people and organisations that have helped us with not only the vaccination programme, but the response to the pandemic. It has taken a huge amount of commitment and collaboration between everybody to try and make sure that people get the services that they need at the time that they need them. So our GPs, just prior to the pandemic, had come together in groups in a particular geographical area as what we call a primary care network. A primary care network is a group of practices working together for the benefits of their population. So they've clearly administered thousands of vaccinations themselves, but they've also helped to support patients with COVID in the community. So they ensure that there's still access to general practice. they've increased the number of digital appointments that that people can get. So it's been a mixture of things that have services that have been delivered through the primary care networks, and they've been key partners in our response. You've heard a little bit about the acute trust providers already. We've had to ensure that we've used our critical care facilities in the most effective way, and also that non-COVID services can continue and resume for patients. Mental health providers have seen a huge increase in the need for their services, both for children and young people as well as adults, and we have been working together to increase capacity, mental health services capacity, to address those needs. The community services providers, I think they've been like the glue between us all, trying to make sure that patients who are discharged have the right set of services when they get home, that they are helped to discharge patients in a timely and easy way. And the voluntary sector, the third sector, has been invaluable in helping to keep those patients at home and look after them, either by providing support at the point of discharge or ongoing support. And as the NHS Clinical Commissioning Group in South East London, we've had a key role in coordinating and supporting all of our providers and our partners to deliver services. So I'm going to, I think the next slide is a little video. So I'm going to leave my section there, and I'm available for questions afterwards. Thank you.
Thank you, Angela. And just to let everyone know that the link to the video will be in the slides. We're slightly running over time, so I think we should move straight on to the next set of presentations, which hopefully will answer some of the questions that have appeared in the chat. So could we hand over to Andrew Bland, who's the Chief Executive Officer Designate?
So Rosemary, thanks very much, and everybody, welcome, and thank you for joining us. As Richard said, great to see so many people and interest. So I've only got 2 slides, and arguably the least important part of this was I want to come on to Ben Collins, who's going to talk about the priorities of the ICS, and you've already heard about some sort of real life examples of partnership working. So I guess that's where the action is. However, come the summer, 1st of July, in fact, we are expecting a change in the law. And for those of you who are most interested in those institutions and statutory bodies, there will be a change. So a number of us on this call, and indeed you would have interacted with us, some of you have worked for and served a clinical commissioning group, or a CCG for South East London. And on the end of June, 1st of July, if the law changes, then that organisation will be disestablished. But its responsibilities won't, and they will transfer to what will become known as an integrated care board that will support our integrated care system. So just a few things around that. Integrated care systems, or ICSs, I think the most important part of this slide is to be clear, that penultimate bullet point, a shorthand for partnership working. They are a system, not an entity, so we bring together all of those players and partners, including residents, that make a difference to people's health and well-being in any part of our geography. There will be, as I've said, supported by a statutory board, and that's what I'm going to be chief executive of, and that's what Richard is going to be the chair of, and that will be known as an ICB, an integrated care board. But essentially that is there to support this partnership to succeed. And I'll come on to a little bit about the way in which we like it to operate, but just to be really ultra clear, the board is there to help the partnership do those things at the top of this slide, those 4 objectives around improving outcomes, tackling inequalities now exacerbated by the pandemic, ensuring value for money, but also that we live within our means, that we don't spend more than we've been allocated as a partnership, And I think really importantly, that fourth one around the broader support to the social and economic developments, the idea that our partnership is not just the NHS, it's the NHS reaching out to the voluntary sector, to councils, and of course working hand in glove with our residents. So a little bit more of that in a moment. There has been a distribution of a draft constitution. Our statutory body will have a constitution. It will be a public document, and it will describe the way in which we will govern ourselves. And I know that for some people on this call, that will be an important document. For others, one that unlikely to be top of the priorities for reading. We've issued it alongside this session quite deliberately. So we have an opportunity to talk about the ICS. But of course, if you then want to delve into that constitution draft, it is not finalised, with opportunity to reflect on it. Please do come back to us. And Rose, will be grateful in the chat if we can describe the easiest way to come back to us with any questions you might have on the detail. For our part, in terms of this session, though, I wanted to make a couple of things clear about difference. Our chair, Richard Douglas, talked about that at the beginning. So we've been a partnership for a long time, and we, I think, work together well, and some examples of that have been put forward. But there are some things that we really want to attend to, and we are intending that difference to focus on three things. First and foremost, we will be interested in populations over and above any one institution that serves them. So we are expecting to operate at very local level, neighbourhoods, or ward level, and be interested in the types of populations that exist there and live with each other, and that's where you have a lot of your local services. We'll be interested in partnerships that are at a borough level, so we have 6 boroughs, and you know them, but really important, particularly with our connectivity with local government and what councils have to offer their local residents, and then we will also operate at a South East London level, and really, and people would have heard me speak about this before, because when you start getting hospital care and specialist care, you don't usually stay within your borough in South East London, although you rarely leave South East London itself. So you very often might have a cancer diagnosis in Bromley or Bexley, but find yourself receiving a large amount of your treatment over at Guy's Tower in London Bridge or in Southwark, depending on how you define it. So partnerships at each of those levels is our first felt difference. Second is that, I've alluded to it, that we reach beyond the health service. We think that the vast majority of things that make a difference to people's well-being, how they feel, exist without the health service, or out with the health service, but we have a major contribution to make to it. So we are looking for a partnership with not just the NHS and people like me speaking to other people like me, but in each of those geographies, neighbourhoods, borough, and at South East London level, we're bringing together the right group of people to make a difference. And a lot of those people will not work for me or work for the health service, but will be in local government, the voluntary sector, or the whole plethora of community assets that we have at our disposal. And thirdly, we are absolutely serious about a principle of subsidiarity, or taking decisions as close to the people who are affected by them as possible. But we are literal about that. So we think that by and large, those decisions will be best made locally with local folks. But we do think there are some decisions that should be taken at a South East London level, and they will most often be around some of that complex care. I've used the example of cancer, or specialist interventions that all of our residents rely upon. So I wonder if we could go to the next slide, please. This is my second and sort of final slide, and again it continues this theme of difference. So as and when the integrated care system and its governing boards, the ICB, come about in July, we are not seeking to replicate any of the organisations we've previously had before, be it a CCG, a Strategic Health Authority for London, or any one of its sub-regions. And we are not seeking to recreate primary care trusts for those people who remember them. We are looking for a difference, and that starts with the way in which we act. So we are hoping to engage people meaningfully and consistently. We're hoping to convene partners to help them do things rather than see everything as being dictated by a central office that perhaps I'm running and with Richard and colleagues. We're seeking to understand more and have an evidence base for what we do, and we're looking to enable improvement. I've skipped over delegation because that's my final point. If we're to be serious about subsidiarity, we do want to delegate our responsibilities to groups of people who are close to residents or close to the issue. So we understand that in two ways. We would like to delegate to local care partnerships of health and care contributors in each of our boroughs, and we would like to delegate our powers and our resources to each of those boroughs to take local decisions about your local general practice or about your community nursing service or about how social workers interact with the health service where you live. But at the same time, for other issues, elective or planned care, or when you have an operation at a hospital, we very much like to delegate those decisions to our provider collaboratives. So groups of bigger trusts in our case, so in South East London, Guy's and St Thomas's, King's College and Lewisham and Greenwich Trust on the physical side, or Slam and Oxley's for mental health, to take decisions about how some of those pathways work. And we want to make sure that when you put that back together, we have a coherent whole that's making a difference for our residents. So hopefully a little bit of a view as to how we will work differently, very focused on local interaction, because we believe that will make most difference for our residents. I'm now going to hand to Fiona, and that there is some degree of segue in that Fiona is helping us to part of that working differently, a collaboration of our acute providers. So I'll hand to Fiona. How'd you go?
Good morning. Thank you, Andrew. So I'm Fiona Hadjigo. I'm the Managing Director of the South East London Acute Provider Collaborative. And I'll just spend a very few minutes telling you a little bit about the collaborative and what we do as part of the ICS. So there are 3 acute trusts in South East London, which you can see on this tiny map, which we've got Guy's and Tommy's, King's and Lewisham and Greenwich. They have many sites scattered across the patch, not just the big hospitals that you're familiar with, but smaller sites as well. What the Acute Provider Collaborative, the APC, is, put simply, is it is a new way that we've come together in bringing those 3 trusts to work together in new collaborative ways on priority pieces of work, similar to what Angela said earlier, harnessing the whole to make the whole better than the sum of its parts. And by working together in new ways, the idea is that we will improve the care and the quality of care that we can provide to all of our patients. And sorry, the acute bit, hopefully acute provider is familiar to you. That means we're distinct from the mental health and community partnerships and providers we have on the trust. Acute providers are ones that have inpatients, outpatients, often have an A&E, and in our patch range from quite small hospitals all the way to the large teaching hospitals in the boroughs. So on the next slide, I will give you a very quick summary of our sort of the journey so far. You'll get these slides, so I won't go through it in detail. But we came together about 2 years ago when the first COVID wave hit, and suddenly the 3 providers who had hitherto been distinct organisations, normally working completely in isolation, had to come together and work differently. And it worked really well. And there was a view that actually, if we can work really well together in the pressure and the challenges of COVID, why don't we do it together more often? So the Acute Collaborative was born. It continued to do more collaborative working during the second COVID wave, but we said, why don't we come together to focus on areas where we have particular challenges? And for us in South East London, the same as every other system in the UK, the biggest challenge we're facing at the moment from an acute perspective is the length of our waiting lists, our elective and diagnostic lists. So that is planned care where you've been to a GP or a dentist or an ophthalmologist, and they have referred you into an acute setting for an outpatient appointment, diagnostics and some treatment. The lists of those patients needing to be seen grew enormously in the 2 years we've seen since COVID, and some of the waits became unacceptably long, and we said we needed to do something collaboratively to fix that. So on the next page, I've got a really summary diagram which gives a very simplified view of a patient pathway. If you were referred from a GP for some surgery, this is a very simplified path of the journey you might take as a patient. And what we're doing as a collaborative, working across all of the 3 trusts, is to look at where can we inject some coordination and some new initiatives to make that process better. So that might mean faster, it might be more efficient, to make it better so our patients can be seen more quickly in the right setting and get the right care at the first point if we can. So some of these are thinking about working more closely with our primary care colleagues so that they can get access to consultants to get advice when they're thinking about a referral. We have thought about some more technical stuff. We've built 2 new operating theatres out at Queen Mary Sidcup to make sure that we can put patients through their surgery more quickly in a better and a brand new setting. And there's some really basic stuff about looking at who is on a list and making sure we've got the right patients sitting on the right waiting list so that when they do get called for an appointment, it's the right appointment in the right place. There's some more detail which you can have a look at when we circulate the slides. And then my final 2 slides are just to bring to life a little bit more some of the actual things that we've done. So towards the back end of last year, we opened 2 brand new operating theatres at Queen Mary's Hospital Sidcup. They are dedicated at the moment to gynecology and general surgery patients. So patients from all over South East London can be referred into this fabulous new operating environment. The surgeons love working there, and our patients have really enjoyed being there because of the quality and the newness of it, and the speed of being able to be seen at this new facility. And then my final slide, another example of what we've done to help you understand the point of the collaborative, is we've developed some additional community diagnostic facilities. So we've set up 2 new facilities for short term, and we're developing hopefully 3 or maybe more new facilities in South East London to get people access to diagnostic facilities. So we've had great feedback because we've been working over weekends, we've been working late in the evenings, which has really made the service more accessible for patients and has got us through over 3,500 additional scans that we've done in a number of months. It's been hard for us to work in this new way, as all of our colleagues in the collaborative will testify, but it's really working well for our patients and reducing huge reductions in our waiting lists, which is the right thing for our patients. So hopefully that was helpful, but Ben can pick up and tell us a bit more. Thank you, Ben.
Super, thank you very much, Fiona. So Andrew gave us an overview of the new architecture of our integrated care system, and Fiona has talked a little bit about partnership working in one really important area, which is how our big acute hospitals can work together to better use their resources and deliver care. I was just going to talk a little bit about the overarching priorities that we think are going to guide the work of our system over the next few years. So as well as all of this work on the architecture and the transition to the new system, we've been thinking about what really matters. What are the things that are going to deliver a step change in the quality of care for local people? I think, certainly 4 of the priorities on this slide will feel quite familiar to everyone. So it's really fundamental that as a system, we complete this transition from a health and care system that focuses on treating people when they're sick to becoming a system that's much better at supporting people to stay healthy and happy and well. So that's the number 1, I think, task for us. How can we become better at prevention, proactive, early intervention in care to keep people healthy and well. Secondly, like health systems really around the world, we have developed over the last few decades a very fragmented system, because as people's health needs have changed, we've tended to add little small services to our system, and the result is a quite complex, fragmented system that as a service user and as a son of elderly parents who are service users, I know how frustrating and difficult this can be when you go from one service to the next, trying to get to the solution. So we really need to think about how we can deliver more joined up and compassionate and whole person care that addresses all of people's health and social needs rather than just part of the problem. And we need to deliver that much closer to people's homes. And then finally, we do need to ensure that when people need access to specialist services, then, as Fiona was discussing, then we need to ensure that they can gain access to those services rapidly and they're at high quality. And that, of course, is going to be an even bigger challenge as we come out of the pandemic. So those priorities, of course, have been well known for some time, and I guess as a system we have to think carefully about why we found it difficult to address them in the past, like other health systems in England and around the world, and think quite carefully about the strategy for making faster progress. I wanted to mention two further priorities that we think will be centre stage in the next couple of years. The first is, how do we, coming out of the pandemic, deliver the best possible care for the most deprived people in our communities? So, socioeconomic disparities between different groups in different communities in South East London are growing. That's translating into huge disparities in health and well-being between social groups. There's a vast amount that we can do to develop our services and target care so that we deliver better care for the most deprived. And then finally, really exciting for me personally, we know that the underlying causes of ill health are socioeconomic. They relate to inequalities in access to resources in society. And we as a health system, of course, we are the funnel for 10% of the GDP of the country. So there's a vast amount that we can do in how we spend our money to support more resilient and happier communities, in terms of things like how we go about recruiting staff, how we procure our services, how we invest, how we use our facilities. So a really, really exciting thing for our ICS, as well as trying to deliver much better health and care services, is to do it in a way that builds more resilient, happy communities as we do so. Can I just so those are the big picture themes, I think, for the next few years. We'll have more work to do in the next in the next few months on our strategy and our planning. Can we go to the next slide, and I will say a few quick words on the Constitution. So as well as the changes to governance and the architecture of the system that Andrew and others have been describing, we're required by law to have a constitution. We've shared with you a first draft of this document. We're following a model that is mandated to us by the central NHS authorities. We don't have a vast amount of flexibility in terms of how we change it. It includes things like how are we going to, the eligibility requirements for the members of our integrated care board, the membership of the board, the process for electing people onto the board, the processes for making decisions in our system, the arrangements to ensure that we are transparent and accountable to the public in things like sharing our board papers and reporting on our work. So I think, Rosemary, correct me if I'm wrong, we will need to put in our revised draft of our constitution to the central NHS bodies by the end of the month, and I think that we're inviting any further questions or comments by the middle of March, but correct me if I got any of that wrong. So that's all I had to say on priorities in the Constitution. I was wondering, Rosemary and others, if I can just pick up one very, very interesting question that came through from Graham Head, who I think is in Healthwatch in Southwark. And Graham asked, well, we've had so many different reorganisations of the NHS over 40 years, and there's such a risk that, as we go through changing the institutional architecture, we will get distracted and the quality of care will come down. What's your solution to that? I think our solution is an extremely good question, but I think our solution is that we need, as well as making the transition to a CCG to a new integrated care board, we need to keep our eyes very, very clearly focused on those big priorities for service change that I've outlined, things like, the shift to prevention, joining up care, delivering more holistic whole person care in the community, and not get overly distracted by the institutional questions, but keep on these questions of what are the care models that would best meet the needs of our communities. And the other thing for me, Graham, is how can we focus more on becoming better as a system at learning, innovation, improvement, and spread of innovation.
Thank you, Ben, and thank you to all our speakers. We're now going to have a 5-minute break before we come back for questions and for 15 minutes of questions.
Welcome back, everyone. That was a relatively short break. We've got a huge amount to get through, and I'm very happy that you are staying with us, and we'll now have an opportunity for a few questions and answers. My name is John T. Heversedge. I am currently the chair of the Clinical Commissioning Group, the CCG, in South East London, and deeply involved with others on this call in the transition that we're now making across to an integrated care system. We have had some questions that have been submitted prior to this session, and I'm going to just take a couple of those that haven't been picked up already in the presentations that we have had, and I think in particular, I guess there's a question that came in, and Andrew, you've talked about this a little bit, but I wanted just to go to you once again, just to emphasize what it is that's going to be different about the ICS and what has gone before. So I wondered, Andrew Bland, whether you might want to pick that up. And in particular, it links with another question that we've been asked, which is not only how is this going to be different, but how are we going to ensure that we don't see any kind of dip in services as a result of the reorganisation? So how are we ensuring that we don't have significant cost or staff tied up in the process of reorganisation itself? I wondered whether you wanted to say a word or two about that, Andrew.
Thanks, John T. And of course, after the session, if it's helpful to pick up any specifics, I guess the difference can be felt in a number of ways. So there is a legal and sort of just straightforward difference in that the type of organisation that receives an allocation of money from central government and determines how it's spent for South East London residents will change. So the Clinical Commissioning Group was a membership organisation of general practices across South East London, of which we have 212 that's elected and chose leaders amongst them to work with people like me to have a clinically led commissioning organisation that let contracts with providers for services and then got into a sort of a transactional relationship with those providers to see how well they were dealt with. And we had called that for the last couple of decades an internal market. So that is being dismantled. The CCG, so one difference is physical. The CCG will be dismantled or disestablished. We won't have that group of clinicians coming together to take those decisions, and instead we will have a partnership board agreed between local governments and the NHS in South East London to set strategy and strategic direction. And we will have a new statutory body, or what I refer to as the Integrated Care Board, that will receive that money but seek to involve a broader range of people. Around that board table, we will have people representing acute, community mental health, social care, non-executive and independent directors, and yes, people like myself to be accountable for the outcomes of those discussions and deliberations. So there's a sort of a physical difference. The second one is that we have tended to reward at least health service providers for the amount of activity they've undertaken, and absolutely insisting and trying to ensure that it is of the highest quality. Sort of a more, not philosophical, but difference in focus is that we will hopefully define outcomes for residents and groups of people, so population focus, try to design services that are absolutely focused upon them and their needs, and recognise that they may well be the same in some regards, determined by places or conditions, but in actual fact the diversity of South East London is incredible, and we will need to localise services, as we learned through the pandemic, to meet individual population needs. So the second one is around focus, rather than a sort of one size fits all or a contract with a hospital for a set of services, bringing partners together to look at what populations need and how that might be different in different parts of South East London and how we can undertake that. And then the final one is, of course, nothing will be different unless we act differently. So we had Ben talk about some of our priorities, and I think broadly speaking, I'm relentlessly focused on how we address the inequalities our population suffer. There were inequalities before the pandemic and now they're worse. We are very, very focused on what we can do outside and with people outside the health service to make a difference on their well-being. So that's another difference. And then this partnership working is bandied around, but it does take a huge amount of effort. And I guess we will be spending a lot of time getting to know each other and making sure that we align agendas, which I think ultimately are pointed in the same direction, but we don't always find a way to connect them up. So John, there's sort of three ways in which I think there might be difference, and depending on what the question was focused on, I guess hopefully I've gone some way to addressing that. To the efficiency or not of or distraction or not of a reorganisation, of course it is always distracting to make change. So you need to make sure, one, is worthwhile, and two, it is minimised. The worthwhile bits, I wouldn't have taken this job or be here today if I didn't feel the greater integration of focus and energy of our partners across health and care wasn't worth it. I think that is ultimately going to be a worthwhile pursuit. In terms of distraction, my feelings, we've minimised it. We merged our CCG to have a place focus over 2 years ago. And in that sense, we don't have some big bang change as perhaps we might have seen about a decade ago, where we did lose time and focus on change. Here it has been iterative, and my feeling is we're moving quite smoothly from a CCG that already operates in this type of way with its providers. So hopefully that minimises the impact. I will not say anything trite, like there is no impact or distraction from change. There is. But I think we have done our best to make sure that will be something that is smooth and minimised.
Thanks, Andrew. And I think I heard you say also, because I just wanted to pick up, I think on behalf of John earlier on in the chat, when you presented, you felt you'd mentioned local government and the voluntary sector, but not social care. And I think I've just heard in your answer here the importance of social care and social services in this as well. Is that right?
So absolutely so. I did see the comments in the chat, and my apologies. The only thing I would say is I am quite deliberately doing it. I'm wanting local government, which includes social care, to be involved. But what we have done before is just involve social care. So I'm quite deliberately talking about the full breadth of local government: housing, leisure, community safety, and yes, absolutely social care. So in amplifying one thing, I'm sorry to have overlooked another.
Really helpful. Thanks, Andrew. And Ben, I wanted to come to you. There have been a number of questions. I'm trying to sum up there just to say to everyone, look, there are loads of questions. We will ensure that we answer all of these and respond. We're not going to get to them all in this session. Really, really helpful questions coming in, as well actually as some useful sharing of resources within the chat, which is why it's so important to involve the community in these conversations. I think, Ben, there are a number of questions that I guess for me revolve around thank you very much for all the fantastic work that's happened during the pandemic. But what about some of those really challenging issues that have really existed prior to the pandemic for people who have struggled to access services, for people who have significant need, for people who are vulnerable in our communities? And there are different examples that have been cited, for example, around discharge. I suppose, broadly speaking, what would be your answer in relation to some of those longer standing challenges that we've faced, and how our transition towards an integrated care system might offer an opportunity in relation to that?
Yes, I think I saw that one of the questions you're alluding to, John T. Well, it's great that we work well in the pandemic, but what's this got to do with these deep-rooted challenges that we're facing in delivering the sort of care that people need in a timely way? On a personal level, as a parent and as a son, I'm very conscious of the challenges that people are facing. If I think about my own interactions with the health system just over the last couple of days, so my mother had a healthcare emergency. She's in her mid-80s. She ended up in A&E and then admitted into a hospital ward. This happened outside South East London, but I think it's the sort of scenario that we that we would face in South East London too. The healthcare staff didn't really know how to coordinate with the social care staff to provide rapid support for my 90-year-old father, who had no way of getting back from the hospital on his own. And it's, you know, for me, with these and other personal experiences of care, it all comes down to things like, you know, how well do the different health and social care and voluntary sector services that we depend upon work together? How well do they share information and coordinate? How well do they work in teams when we've got more complex needs? You know, are they using their resources as effectively as possible to ensure that we can deliver the best possible care? So I think the link with the vaccine programme is fundamentally, you know, we're facing some really big problems in our system, problems that are long-standing in our system as well as in many others in England and around the world. This ICS, I think, is based on the concept of partnership working, sharing of resources, working as teams to tackle these really complex problems. So that's the link. That's what we did really well in the pandemic. That's the skill set that we need to apply to these other challenges.
Thanks very much indeed, Ben. There's been a couple of questions on primary care, and I thought I would just flag again a little bit about what the opportunities are, particularly in terms of general practice. So I think there was a specific question about the challenges people in the local population are having accessing general practice in particular, and I think that was built on by a couple of other people. I think particularly around often the people who are struggling most to access those services being some of the most vulnerable in our communities. And I guess as someone who is working quite closely with general practice and with our leadership across general practice, they very much see the opportunity to think quite differently. And I think this was the comment made by the questioner. In fact, I think there was a very explicit statement made that it can't possibly stay the same. I do think that that's been recognised by GPs across South East London. There's a lot of learning that's come from the pandemic about the way in which they've been able to work together to deliver care differently. So, for example, for people who had symptoms and were experiencing symptoms of COVID, practices came together in boroughs to offer services that enabled them in some ways to segregate patients who had COVID from those who didn't, so they could continue to provide services for those who didn't have COVID and were more vulnerable. So practices are really trying to think about what the learning from the pandemic means in terms of their ability to work together to try to meet both the immediate needs that people have, but also the need that hasn't been met during the pandemic. We know that a number of people have struggled to access services across both primary and acute care, and Fiona's talked about the work that Acute Provider Collaborative is doing to understand that need and to meet it. The same work is taking place in general practice to understand those people who have a range of different complex conditions and needs, who've struggled to access care. How do we now ensure that we proactively provide them with the support that they need? So I think a lot of the focus going forward is going to be on how practices work differently together, but also on how they could be working much more effectively with other community partners. And there was another question, I think, on the disconnect sometimes, for example, between general practice and district nurses and mental health services. Again, this is something that through what are called primary care networks, we intend to start to form relationships that will ensure that people with those more complicated needs in the community are better served by those primary care services. So I hope that's helpful just in terms of some of the broad some of the broad changes that we're going to see around primary care. There have been a lot of other questions. What I'm going to do is I'm going to try to look through those questions for key themes, and in the final question and answer session that we're going to come to, I'll try to pick up as much of that as I can with colleagues on the call. But on that note, I'm going to hand over now to Dr. Nada Lemick, who's the Director of Public Health in Bromley. Nada, can I hand over to you?
Hello, Good morning. I'm Nadia Lemick. I'm Director of Public Health in Bromley and representing actually public health colleagues across South East London. We in public health do quite a lot of work, obviously, on prevention, and that is one of the key areas that we do our work on. But the other area that I want to just touch a little bit upon today is also something that we call health surveillance. We look at what are the key diseases in an area. So we have looked, for example, the first slide shows a Bromley a situation. What are the key diseases that our population suffers from? And this is very similar across South East London, but proportions are slightly different. So the next slide is Lewisham, for example, but also just like Bromley and elsewhere in South East London, cancers are something that is causing one of the top areas or top diseases that causes also mortality, followed by cardiovascular diseases, diseases of the heart and stroke. Sorry, could you go back? Yes, thank you. So just to say, these are the key diseases, so cancers, heart disease, stroke, followed by respiratory diseases and infections as well. So if we look at those diseases, of course, we need to, this is useful for colleagues in the NHS to plan which services are needed to treat those diseases, but equally for us in public health and across ICS now, what are the diseases that we should focus in terms of preventing? And if you look at cancers and cardiovascular diseases, they take up nearly 2/3 of causes of death and causes of illness as well, and in ill health. And if we were to tackle those diseases, their risk factors, what causes those diseases, that would help us very much. And I hope that if we look at what actually makes us healthy or what makes us ill, will be something that the ICS as a new system could help with. Now, can I have the next slide? Yes, and this is a slide from the Health Foundation, which I found really nicely describing what are the main contributors to our health or disease. And if you look at those factors, they're not. Sorry, if we could go. Yeah. This one. These factors are quite broad. This, as somebody said earlier, socioeconomic factors about our environment, and so on. So good work, for example, is something that will be a key contributor for our good health. We know that people who are unemployed often suffer from various conditions more than people who work. Our surroundings, where we live, our houses, good quality housing contributes to our health. Of course, money and resources. We know that if people are struggling financially, they're less likely to lead healthier lives, which will then, of course, lead to better health. Education and skills that people learn in their education are very important. We know that the level of education in population is a significant predictor of how healthy that population is. And that often leads to what food we eat and how we generally behave. So eating healthy food is, of course, linked to the money and resources, but also about our knowledge and skills, how to use ingredients, how to maybe skillfully cook something from using a cheaper but healthy ingredients like fruit and vegetables. Transport, of course, is important. We often say if we could just be more physically active, but if we don't support people to be more physically active, if there are no cycling routes, if there are no parks, of course, people will be struggling to actually live healthier lives. And if transport is supportive for somebody to be more active, that obviously helps. And although it's a final bullet point, but I think it's not the least important. It's probably one of the very important one. Is the community, family and friends. We know that community support, family support, having friends, not feeling lonely is a great support for not only mental health but for physical health. People are much more likely to live a healthier lifestyle if they have a good support in the community, but good family and friends as well. So if we look at these broader contributors of health, I think that the idea and hope is that the ICS as a new system that is looking at health of the population, not only treating diseases, will be in much better place to address those. And I think Andrew mentioned how local authorities have also the social services are not the only aspect of local authorities, and public health now sits somewhere between the local government and the NHS. But local authorities have, and what I think I've learned and public health colleagues have learned throughout this pandemic, that there's joint working not only between various partners in the community, but also for us in public health, working much more closely with other departments within local authorities, like housing, working on people and supporting homeless people. There has been a lot of projects during pandemic in terms of vaccination, where we worked very closely with our primary care colleagues to support, and housing colleagues together to support homeless people, for example. So these are the examples that we could use for the future to build on and use for other conditions, not just as we did for vaccination. So there are many other departments in local authorities, like environmental health services, which could be greatly supportive and help us in achieving some of those aims, and obviously housing. But also local authority has a role in supporting people in terms of education. Obviously, education is still linked to the local authorities, so supporting good education, supporting people to find jobs, which local authorities also have a great role. So linking that element of this much more broader community aspect of health with obviously the NHS side treatment of diseases and good access, and hopefully bringing this together will make a difference for the future. Now, if I could have a next slide, we have a little quiz for you, because we thought it would be really interesting just to see what do you think about the health and well-being. And can you answer those two questions? The first one is, how does your day-to-day life affect your health and wellness? And then what makes things difficult for you when looking after your health and wellness? So if you could answer that, and you can follow your Do Poll link in the chat and answer those, and then we'll have a look at your answers.
Thank you, Nana. I just wanted to say to people, you might need to cut and paste the Do Poll link into another browser, another page. People had difficulties on the first Do Poll vote at the beginning.
Excellent. I'm just going to try and make my screen a little bit bigger to read. Oops. I think we can see some really interesting answers. Pollution is one, and obviously air quality is a hugely important aspect. Stress, hugely, a great deal. Everything, food, sitting in meeting, obviously it's sleep pattern, stress. Sorry, I can't see now there. Again, exercise. How many people need your support, feeling unwell, if allowed to day-to-day activities overwhelm me, and COVID and vulnerable, so various issues with that, of course. Busy bit work, so when I get free time, exactly, energy, mood, facing challenges, wellness. I think, of course it does. I think this just shows, I think this is a lovely list of, really, really rich list of your comments. And I think this is exactly what feeds into what we should be looking at. Stress, not being able to exercise. And of course, what I think is really good, air quality, which of course is a significant factor for our health. So it just shows how the role of ICS, if it could be broadened, and we are hopeful that we will link all this together, will help. Exercise, got to stay in the warmth. You see that's very hearing problems to use the phone. So a lot of, I think these are such a rich, I can't even read all the stress. I think this is stress and psychological and mental health problems. We know that has been a significant factor in people's lives recently. Bit busy, yes. Stress again, balance of feelings, positive, healthy, and happy. Oh, thank you very much. This is great. I think that they're really excellent list of answers. I hope we will, Rosemary, I'm sure we will capture this, because if I would like to have those for other colleagues in public health to be able to share this. This is great. Thank you very much. Now, there was a second question, although I think most people have answered both questions together. So thank you very much. I think this is really, really very useful. There's another more to that. Okay. What makes things difficult? Boris Johnson and the government. Well, navigating the floods of new online health access systems. Okay, that's true as well. So many wanted to short notice. Exactly. Lack of time, lack of resources. Yes. Money. Leading poor work culture, being an unpaid worker and carer. Sorry. Time to exercise after work and childcare, accessing services, not having enough leisure time. Air quality again, yes. Poor work-life balance, poor work, being unpaid carer, immobility. So these two are really linked, and I think it's really a rich responses that I would really be very happy if I could, once we after this meeting, we will collate this, and maybe we can circulate this, because I think that is really interesting. I will definitely share that with colleagues in public health, because that also will, I think, when we look at our, and I know that this is what I've been told by a lot of colleagues to mention, all our areas are going to develop and refresh our health and wellbeing strategies, and I'm just hopeful that some of this will actually feed into those. But thank you very much.
Thank you, Nada. It was really interesting seeing a lot of those views, and it leads us nicely into talking about working with people and communities, because it's those kind of issues that we need to understand and hear from people, so that we can build services, design services, and how we work together to address those wider issues as much as we can. For those of you who are joining since I introduced myself at the beginning, my name's Rosemary Watts, and I'm the Assistant Director of Engagement. Could we have the slides back up, please? We've been working on developing an ICS approach to working with people and communities since last autumn, when NHS England produced its guidance for integrated care systems on working with people and communities. And our approach is to both focus in on communities and people who experience the greatest health inequalities, as well as broaden our reach and widen our approach. So all these approaches or issues on the slide are areas that we need to consider as we develop our strategy for working with people and communities. We are looking at how can we make our ways of working and our governance and our systems more accountable to local people. We need to look at how we can both co-produce and work with people with lived experience in redesigning and developing services, and how we can have people with lived experience as part of our programme decision-making structures. As I mentioned before, and we know a lot of this from our work during the pandemic, which has really shone a light on the health inequalities, that a lot of people and a lot of communities have trust issues, have experienced racism and discrimination in accessing services. So that obviously has an impact on their outcomes. So how can we really work with people who don't trust us, and how can we really understand what is important to them to try and address those issues in how we plan and develop services? And one of our approaches to that, and we are currently out to tender for a small piece of work to start conversations with communities, is to work with trusted local organisations who have a relationship with communities locally, and could could fund them to have those conversations on our behalf and start building up that trust. So we want to really work in an in-depth way with communities and really build up the relationship and have ongoing conversations, rather than what may have been seen that we did in the past as parachute in, have a conversation about what's important to us, but produce much more, move into much more of having ongoing conversations, not only to inform our strategy for working with people and communities, but as Nada said in her section, but also to inform health and wellbeing strategies that are being developed across the patch, and also to inform the wider strategy of the ICS, which will be developed over the next year. So we want to really deepen our approach and build up trust and relationships with a lot of our communities where there are unfair differences in health, but we also want to broaden our reach as well, so that we can make more of an inroads against into our population, which is 1.9 million people. So that is a challenge for us. One of the things that we're doing, we are developing an online engagement platform, and the link is there and will be in the slides which we send out. We're still developing it, but it's a forum where we can have open and closed chat discussions. We can have questions and answers. We can post little films and talking heads to try and make our ways of working with local people more engaging, as well as do more traditional approaches like surveys. So this is some of the challenges, and we want to put in place ways of addressing these. We have set up a steering group after the guidance was published by NHS England, and that's been chaired by Anu Singh, who some of you may know is the independent chair of Partnerships Southwark, but she has also worked as a director of engagement at NHS England. So she has put together a steering group which has included people working across the system in different organisations. It's also included local people, and we've also had challenge from academics working in this field as well. So we wanted some constructive challenge and to stretch our thinking. We've also had conversations with members of the public who sit on the CCG's Engagement Assurance Committee, and we've had some discussions with the Healthwatch South East London patient group as well. We have set up an engagement practitioners network for all those people working in engagement across the health and social care system across South East London, and we've had a lot of in-depth discussions there, as well as at a broader comms and engagement working group that's been set up as part of the system. So with the timelines, we have to submit a strategy to NHS England by the end of May. So we are, as I mentioned earlier, commissioning some further community engagement work to have some of the conversations that we've started today with the questions that Nada posted. But we also want to understand how it would be easier for people to give us their views and to engage with them in a more ongoing way, in order to inform both our strategy and the broader strategy of the integrated care system. And we will be putting similar questions up on our platform to try and broaden engagement into that as well. Could we just move on to the second of my slides, please? What will be coming up in a moment, thank you, is we've also, through all those groups and meetings that I've just described, we've developed a draft vision and mission statement for working with people and communities. So this is just for that element of the integrated care system. This is not a vision or mission statement for the whole integrated care system. But our vision for working with people and communities is to work with local people to build a healthier future for all communities across South East London. And our mission is that the ICS works in partnership with local people and communities. This improves health and well-being and supports people to thrive and live healthier lives. We will prioritise working in partnership to address health inequalities. which we then describe as, which are unfair differences in health between different groups of people, because we've had a lot of feedback on our language, and has even the term health inequalities doesn't mean much to some people. So we've tried to explain, and this is a challenge for us moving forward in all our work, is how do we move things away from the way we typically talk about things in health and care, and try and put things into everyday language without losing its meaning. So that's it from me. I'm handing back to Jonty to facilitate the final question and answer session.
Thanks, Rosemary. Really helpful. And actually, I think what you've just been talking about does respond to some of the questions that we've seen coming in. I'm incredibly thankful for all of the questions that people have been sharing. This is such a rich session, and we will absolutely be capturing the questions and ensuring that we respond and we provide the feedback from this session to everybody. But thank you so much for the involvement. I'm going to try to clump up some of the questions that have been into some themes to address. And one of the things that I wanted to come to, just building actually, Ben, on what Rosemary's just been talking about a little bit in terms of the wider plans for continued involvement of local communities and the public in the work we do, is from your point of view, how we will continue to ensure that the public voice is right at the heart of what we do at every level, so including sort of the governance and the work that we do within the ICS. Did you have a few words that you wanted to add to that? I do think we have got people already volunteering in the chat to be involved in the governance and oversight of the ICB, so it'd be helpful to hear from you about how people might look forward to doing that.
So I didn't have too much detail to add, Jonty, because Rosemary is the expert on this, and of course we have the process that she set out to hammer out the details of how we involve the public in the ICS over the next few months. I did want to just sort of share my huge enthusiasm, because my sense is that, you know, that learning and innovation and being able to look differently at long-standing problems is really, you know, that will be the secret of success of our ICS. And it strikes me that our partnership with the voluntary and the community sector, and with patients and the public, that is, you know, that is potentially our secret weapon in this. Partnerships that allow us to see common problems differently and reveal new and potentially better ways of supporting people. So on a personal level, I'm really excited. My sense is that often in the past, health systems are focused on involving the public in accountability or in sort of you know, formal engagement on service change. I'm hugely excited about shifting to a system where we can give more hands-on roles to community members in our work. So we've got community members as part of our team, supporting us on a sort of wide range of issues, from strategic priority setting down to our models of care. So it's a really, really exciting thing. I do think that there's a really important job for us in ensuring that in this process we give a voice to the sorts of people that we have struggled to give a voice to in the past. I'm thinking, you know, for example, single mums, you know, young people with mental health challenges, people with learning difficulties. There are particular groups that we really, really need to try hard to give voice to. And to do that, we're going to have to think about things like how we reimburse people and how we support people.
Thank you, Ben. I wanted to bring Andrew Bland back in. Andrew, if that's okay. I realise I'm putting people on the spot a little bit, but there are a number of questions about money, and these essentially range from, is this just a way to save money? To how are we going to ensure that we get a fairer distribution of funding across boroughs and services, and in particular people have flagged, for example, mental health services. So I wondered whether those are kind of, you know, there's broad principles that sit behind that, but I wondered whether you might give a couple of thoughts around the opportunities in terms of funding.
Thanks, Jonty. So I guess there are those things that represent opportunities, and those things that are happening with and to us. On the latter, so I'd would share concern about if we don't change the way in which we incentivise and remunerate and use our money, then we're unlikely to see different results. And I think Ben has spoken to that. Just to say, although we are changing, CCGs are going and other three-letter organisations are coming, what we do have within that was the 5-year forward view nationally, and then a national set of guidance and perpetuate some of the guarantees there. So we will into the next financial year with a guarantee that the rate of growth in allocation for primary care, community care and mental health services will be greater than the general growth to the health service, and we will be required, as CCGs were actually, to demonstrate that we have spent to that growth allocation. Mental health investment standard has been knocked around as a code for quite a formal process to ensure that we are making that increased investment in those areas. And I think that's something I'm looking forward to. That upstream investment and also that parity of esteem point is important. So that's sort of happening whether the ICS comes about or not. Within the ICS, of course, looking across our geography and the way in which we spend our money probably presents two opportunities in broad terms. The first is that we can work with people like Nelda, but also people on this call, residents, to see what the return on investment for our money is, and also the way in which it is allocated. It is straightforwardly the fact that across our 6 boroughs and the various connotations of the health service over time, we do have historical difference in our starting points. There's no doubt about that. And what I've come to learn, though, as I get more involved in each of the boroughs and then compare and contrast, some of the assumptions around disparity of spend or otherwise, when unpicked, are not necessarily as they first appear. And in actual fact, I've learned from the pandemic and our work now that the difference we must really look at is usually within borough and between wards and neighbourhood areas, a greater disparity than one finds between Bexley and Bromley or Lambeth and Lewisham, or whatever comparison you're seeking to make. The other opportunity is just to invest differently, but also how we consider our spends with colleagues. So our local care partnerships, those partnerships that talked about at borough level, are an opportunity. They're not a requirement, but an opportunity we are making to take decisions about how money in local government, particularly social care, since it was raised, and public health is spent in a joined up way alongside health service monies. Now, not pretending that anybody is awash with funds, least of all local government, but we do have an opportunity around the same decision-making tables to align our spends, and I think that's an opportunity not to be missed. Ben's given the example of his mother. I'm sure that many people on this call will have similar examples where joined-up care, not only is it not the care you would like your relatives to receive, it's actually become at quite a cost. It's been more expensive than it needed to be as well. So we have those opportunities. And I'm sure more, John, see if others want to contribute, but that's the sort of starter from me.
Thanks, Andrew. So what I'm hearing is that whilst this absolutely isn't being driven by an imperative around reducing cost, it does create the opportunity to think quite differently across the system in a way that joins up care, which we know by enhancing the quality and experience of care people receive will result in better value to the system. And that does feel quite important. I think the only other bit that I might just build on that is that some of the questions have related to variation that is not about cost, it's about the way in which services are being delivered. And I know if Sarah Cottingham were on the call, which she isn't, she would want to talk a little about the work that she is doing to look at how we get a more consistent standard of services across our boroughs. There's been specific mention in the chat around discharge, for example, and the support that there is for people following a stroke. So I think there are a range of opportunities, and the balance here that it feels is coming across to me is that there is an opportunity to try to seek some of that kind of consistency, but at the same time we have to ensure that the best approach to addressing inequalities and reflecting local need is going to be through that place-based working. So getting the balance right between what happens at an ICB level and what happens at a place level is going to be key. So thank you, Andrew. I think that's really helpful on the funding side. That has come up a fair amount. I wanted just to touch one of the other questions that's been coming up quite a lot, and I'm hoping, I know I'm putting people on the spot a bit, but Fiona, one of the things that people are rightly raising is that it's all very well us talking about this, but actually the problem we've got is that we just haven't got the people to be able to deliver care at the moment. I realise this isn't absolutely in your bag, but any thoughts you've got on the workforce challenge? And I might after that just briefly bring Ash in to think about the opportunities that there are that we've been looking at in the community, particularly around pharmacy. But Fiona, did you have any thoughts from an acute perspective?
I mean, I think whoever's raised it, or those who raised it, you're absolutely spot on. It's one of the biggest challenges we face at the moment. Our workforce have had 2 really trying years and they are exhausted, and there's a lot of movement within our workforce, so it would be remiss of us to try and do any of this dramatic change without putting the people who work for us right at the top of the way we think about things. So, I mean, the workforce within the acute setting is very specialist, so there's not one size that fits all, but we've got a range of initiatives that are going on to help us maximise and support our workforce as well as possible. As examples, we are looking at how we can share our workforce better across the hospitals, so make it so that consultants, for example, can move across our sites and be as productive as possible. We've got various recruitment, locally, nationally and international recruitment going on at the moment, which is a short-term fix, but there are initiatives going on as well to think about how we can grow our own workforce, how we can start people on training programs and develop people and use staff in different ways. So there's a lot going on with different specialisms across the trusts, but we don't underestimate that huge challenge that we've got, and we're doing all we can to address it.
Thanks, Fiona, and thank you for being willing to touch on the work that you're doing on that. Just very briefly, Ash, I don't know if you're with us still. I know there's been a lot of work happening in the community to think about how we use pharmacy in particular differently, given some of the challenges we've got on workforce. Did you want to say a few words on that?
Thanks, John T. Yes, obviously one of the things from a pharmacy perspective is that throughout the pandemic we've been there and available for the public, and we're at vaccination sites across the borough. We have lots of contact with the public and almost hyper-local relationships, which are really useful to be able to get to understand some of the things that the public think, because sometimes people come to us where they won't necessarily go to other parts of healthcare, and see us as an opportunity to ask for advice, to ask where to go. And that link that we have, because we work with health and social care effectively in the way we operate, gives us a real opportunity to be close to those communities and to be a point of contact and a relationship with the public. Talk about community connection, where pharmacies across the whole of South East London are very close to the public across the whole area. And as I say, it's a really easy point of contact that the public do use and could easily be used more to help us develop. And we've got a massive workforce. We've got we've got the professionals in there, but we've also got health champions who are there to provide support around health and well-being. So there's lots and lots that pharmacy can bring in, and actually one of the things that we can see as an opportunity for things that potentially currently happen within general practice to be better managed in the future, to give general practice more time to do some of the things they need to do going forward.
Ash, thank you, and again thanks for being so willing to be put on the spot with that. I think just in rounding up, there have been fantastic resources shared. There's been an amazing conversation going on in the chat about unpaid carers, who of course are such an incredibly important part of our workforce broadly, really, because actually they contribute enormously to supporting people with significant need in our community. The other questions have been a little bit around digital. We haven't had time to touch on that, but I think just to flag that one of the key opportunities through the work of Beverly Bryant as lead for digital across the ICS is how we do connect up much more effectively than we do at the moment, because that's part of providing that seamless experience of care that we know is so important to people. So just recognising that we're absolutely looking at connecting up the information that we have on people to support their care. But we are also recognising that with some of the changes that there have been in terms of how we deliver care during the pandemic, and I know a number of people have been challenged by the technology on this call alone. We know that it can be excluding, so it's really important, and we're giving a lot of attention to the impact that potentially a move towards more digital technology could have on our most vulnerable in the community. Again, we do know that particularly those people who live in more deprived parts of South East London will have less access to digital technology. That means they will potentially have less access to care, but importantly, it probably also means they have less access to resource to support themselves. So it's really important that we address that as an ICS. So thank you again for flagging some of the digital challenges that there will be in terms of inequality, but also in terms of the opportunity to connect up better. I am going to, at this point, hand over to Richard Douglas, who started the conversation off, who I hope is going to round up. And Richard, I don't know in doing so whether you wanted to also touch on any of the particular questions that came up. You may have some answers or contributions that you wanted to make, but otherwise I'm going to hand over to you as our chair to finish the session.
Thank you very much, Jonty. And if I can sort of close up, I will take the advantage of what Jonty said about just reflecting on that group of questions. I think that we're both about money, but about variation in service and variation in outcome. I think one of the things that you really need to hold us to account for as we go through this is our transparency around all that. Yeah, there's lots of questions about, well, how does money vary across different parts of the system? How's it vary in sector? How does service delivery vary across our boroughs? How do outcomes vary across our population? One of the things we have to do as an ICS is get that information on the table in a way that is fully accessible to people, so people understand that and can hold us to account for how we make change on that and how we improve things. So I think we have to come back here in a year's time. I said to you at the start, we're not going to change the world overnight, but one thing I can think we can do overnight is get that transparency around that key information so you can hold us to account. So just a very brief point on the questions. But apart from that, thank you, all of you, very much for your time today. I know taking up 2 hours on something like this is really difficult to people. And thank you very much for the questions from everybody. Thank you also to all the presenters today. There's a number of questions we probably haven't answered here. If we haven't, we will find some way of getting back to you on them, and we will work on your feedback. This Rich, is not, sorry.
Could I just remind people about the do poll? Sorry to cut over you there, but we wanted to come back to the do poll at the end.
Okay, I will. You have reminded us, Rosemary. When I finish speaking, we will put the do poll back up. So this isn't the end of the process. I think, as Andrew said earlier on, we'll have a number of engagement events, not just sort of big cross South East London ones, but also ones at the neighbourhood and at borough level. So thank you all for your time. And as a final farewell, if I can ask Rosemary just to put the poll back up.
Thank you, Richard. Diane, I think you're going to put the poll back up for us. I think you put it up, but it's not the last thing in the chat. Thank you. And again, I'm struggling with my eyes to see that, but that looks like 67% of people know what the ICS is, and 32% don't. So we have made some headway throughout today, which is good for us and good for you, hopefully, because it was 56% at the beginning who knew what the ICS is. If we could just look at the second question, Diane. Do you know what it means for you? Yes, 35%. So we have moved on that from 23% earlier, but clearly we've still got a way to go. But as Richard has said, this is the beginning of conversations and webinars that we will be having. So hopefully we can all grow and learn and understand what this means for all of us together. So I have nothing further to add, but thanking you all for your time this morning and for your questions and comments. And thank you.